All right, here we go.
Let's see, we got it going.
On Monday, June 5th, 2017, I felt the worst headache in my life, like an ice pick driving through my skull. CAT scan revealed a bleed in the side of my head, the size of a softball. The only option to stop the bleed was to have a craniotomy to remove it. Being completely out of control is terrifying.
It's difficult to talk to patients about brain surgery because it's very abstract. We're combining delivering difficult news about a scary diagnosis with the additional fear of not knowing what to expect and not being able to understand what it is I'm explaining to them. When we show them the model, when they fly inside their own brain, they can see the structures, they can see the tumor, they can see the aneurysm.
This device creates an experience for the patient where nothing is unknown anymore. I'm not a doctor, so I couldn't understand what they were trying to tell me because I had never physically seen a craniotomy before. It's so hard to wrap your head around what they're about to do. When I put on the goggles, my surgeon asked me if I was ready to fly. In the moments where they were telling me really terrifying things, I felt a little bit of peace from the way that it was being presented. I was able to, in real time, see inside my brain. I was physically there with them, looking at exactly what they were trying to communicate.
Before surgical theater, preparing for surgery was literally me sitting over a cup of coffee, kind of thinking, okay, I'm going to do this. And then I remember that the optic nerve is here. But those preparations were a kind of ad lib. Now, with 360-degree 3D reconstructions, we're able to be inside that environment, which is as close to brain surgery as we can actually get without being there in the operating room. The advantage that the virtual planning and rehearsal brings to our readiness for surgery is the ability to simulate multiple different approaches. In a real patient, we don't get to try that more than once. We only get one shot at it. In the virtual model, we can do 2 plans, 3 plans, 5 plans, and see which one is the best for the individual patient. Make the bone look a little more like bone, so it's not translucent at first. Now that I can see the frontal sinus, I'm planning it, yeah. When we're in the operating room and we get to the time of surgery, because we've done the preoperative rehearsal, it kind of feels like deja vu, like, okay, I've been here before, I know where the important structures are going to be.
Here we are, we're coming up to the back of the tumor right here. This would be a good place to do an overload. Make the tumor more translucent.
I was at the hospital in the ICU for 10 days, and I had 2 angiograms, 2 MRIs, 2 CAT scans, and a craniotomy. I had a risk of having epileptic seizures for the rest of my life, not knowing that I'd ever be able to drive a car again, that I would ever be able to run again. But I would say the biggest testament to how everything went was the fact that I'm sitting here today. It was nothing short of a miracle. It made me more grateful for each and every moment that we have. We experience life in 3 dimensions. Why should our medical care be any different?
So I'd love to show that quote at the beginning of my talk, that video, because it just describes or shows Danielle's journey through what her journey was through brain surgery, and that was how I got introduced to VR. In fact, this video got over 1 million views on YouTube. It's partly because Danielle is so great at explaining the value of this technology. But really, when you look at it, my first foray into virtual reality was using this for patient engagement. And if you kind of look at the images here as a surgeon, we're used to showing patients these 2-dimensional Rorschach blots, and what I call Rorschach blots, what a standard MRI is, and now we have these 3-dimensional images we can show to patients and literally fly them through their own brain. So we can use these to prepare ourselves for surgery. We can also use them to help our patients prepare for surgery and give them a better understanding of what the operation is going to entail. We've actually studied the impact of this on our patients at Hoag. These are our patient satisfaction scores based on 360 VR consultations using surgical theater. And when the patients fly through their own brain, the patient's ratings are nearly 100% of patients are saying that the doctor explained things in a way they could understand, and 97% giving the hospital a 9 or 10 out of 10 after the experience. These compare to national averages of 75 to 77%. This also had a significant impact on our patient retention. So the best way to measure patient engagement is patients vote with their feet. Prior to implementing virtual reality for consultation during surgery, 64% of our patients would stay here, meaning our out-migration rate was 36%. After implementing patient-specific VR fly-throughs, our retention rate went up to 96%, meaning only 4% of our neurosurgical patients were leaving our Hoag health system and going to other nearby health systems. This had an incredible impact on both our patient engagement as well as the hospital's bottom line. This has also been replicated in other specialties beyond neurosurgery, including heart. So this is a paper published in Structural Heart with a similar increase in the conversion rate for both TAVR and Watchman procedures when the patients had a 360 VR fly-through prior to their procedure. So going from 68% to 100% conversion rate for the TAVR procedures. And again, this speaks to the engagement or how engaging virtual reality is in helping patients to better understand their planned procedure. So these are 3 different specialties now, before and after VR. So adult neurosurgery, adult thoracic surgery, and adult interventional cardiology. Level of understanding at 9 out of 10 before VR, 28% up to 89%. For thoracic surgery, 59% up to 94%. And for interventional cardiology, 26% up to 88%. Now here we're saying almost 90% of our patients are rating their level of understanding of their brain surgery as a 9 or a 10 out of 10. Now, unless I'm only treating brain surgeons, we're unlikely to achieve that level of patient engagement with any other technology other than virtual reality. And in fact, Forbes rates virtual reality as the #1 technology for patient experience in healthcare. Forbes isn't in the business of medicine, but they're in the business of business. So I trust what they say in this, and we've taken their lead. So we have gone large scale with deploying virtual reality at Hoag over the last 5 years, including completely reimagining the patient experience. This is an enterprise solution. So we now have a central command center where all of our virtual reality images for all different types of surgical and medical imaging are constructed and then routed to the different clinics for brain surgery, spine surgery, heart and lung surgery, pancreatic surgery, gynecologic oncology, urology. All of these now are taken from the models are built in our central command center and routed to the different clinics. And in fact, behind me on the screen, if you can see my screen, I'm actually have a view of the operating room. There's a case going on right now in the middle of an acoustic neuroma surgery, which my ENT colleague is performing with the help of this technology as we speak. So based on the patient experience at the center, Hoag has developed an XR deployment strategy using these kind of 3 orbits of what I describe as where the research stands in each area. So with the idea that the patient experience is central to all of these technologies, we then are looking to deploy technologies which are already evidence-based. And I'm going to go through a couple of examples of those. We are looking to research or study technologies which have some evidence basis but aren't quite ready to be deployed. And then, in conjunction with commercial partners and our clinician leads, we are looking to develop and are developing numerous technologies to meet unmet clinical needs. So, starting in the deploy sphere, with the patient experience, we targeted the #1 thing as pain management. We have a massive opioid addiction problem in this country. We've caused this problem as physicians. You can see the number of opioid deaths, nearly 50,000 per year. This is half of the number of people that have died from COVID, and yet we aren't even making a dent in this problem by handing out these numbers. In fact, I just saw a recent study that shows we haven't made much of a significant decrease at all over the last 10 years. This is an interesting chart from the CDC, which shows that at 5 days, the likelihood of inpatient opioid administration, the likelihood of becoming dependent at 1 year is nearly 10%. This is people that were previously opioid naive. If you take it out to 3 years, still after only 5 days in an opioid naive patient, the risk of opioid dependence at 1 year is 6%. If you go up to 10 days, you're looking at 20% risk of opioid dependence at 1 year in opioid naive patients. This is a problem we have to solve, and virtual reality is one of the tools which we believe is in the deploy category to managing pain. In a recent meta-analysis with almost 500 published studies, the majority of these studies definitively demonstrated that virtual reality helped decrease pain both during and after both medical procedures and surgery. That's pretty profound evidence. In fact, I did this kind of comparison of virtual reality versus fentanyl using Dr. Spiegel's data. With the patient with an average VAS starting at 7, the mean reduction in VAS score with the virtual reality session was 3 points on the VAS score, which is equivalent to a 50 microgram dose of fentanyl. The duration in mean effect or of peak effect is approximately 20 minutes for VR versus 30 minutes for fentanyl. So the fentanyl lasts a little longer. The cost of VR, this assumption is based on if you use the headset 100 times and then throw it away, is still significantly cheaper than using fentanyl in each patient. That is to say nothing of the adverse side effects, which we know are associated with fentanyl. The list goes on and on and on, including the risk of dependence, addiction, overdose, and death. So we know that fentanyl and morphine and Dilaudid are a bad choice for pain. In fact, they don't really treat pain. They just make you not care about it. So we can do better. We also know for chronic pain that teaching patients about their pain has a significant impact on pain control. In fact, there is level 1A evidence in 3 separate studies to show that procedural pain knowledge has a significant impact on pain control and recovery time, which is why we put the using VR for acute and chronic pain in the deploy category, meaning we don't need to study this anymore. We are just rolling it out in broad scale to our patients because we believe they will benefit, and any dent we can make in the opioid consumption is worth the effort. The impact of using this preoperative or preemptive pain neuroscience education is multifactorial. It decreases time spent thinking about pain. It decreases the worst intensity of the pain or the sensory aspect of the pain. And it also decreases the emotional unpleasantness or affective aspects of the pain. This is a study from Behave VR showing the majority of patients, or 70%, showing improvements in their global rating of change. In other words, after VR pain neuroscience education, the majority of patients had a significant improvement in their pain levels. Why is this so? Because as Dr. Spiegel mentioned, as compared to handing them a handout and saying, here, learn about this, and they're kind of using only the cognitive system, which gets easily overloaded and bottlenecked, VR, by nature of its immersiveness, captures all 4 learning systems. So 90% of our waking sensory input is visual and 8% is auditory. So by immersing someone in visual with VR, we are capturing 98% of a waking person's sensory input and thereby hijacking the cognitive, experiential, behavioral, and emotional learning systems to accelerate the learning curve to a level that is not seen with any other type of technology. So we accelerate that ability to learn about their pain and why they have it, and teach them techniques to downregulate it through descending pain pathways. We also have deployed, in the deploy category, physical therapy. So we know the attrition rate for physical therapy is nearly 40%. We also know that that there's poor ability to objectively track progress. So virtual reality headsets, these data from XR Health, has been shown to be better than standard of care, for example, goniometers for measuring improvements in degrees of freedom of neck rotation, degrees of freedom of shoulder rotation. So there's improvement in both patient engagement and the ability to track the outcomes. So again, putting VR for physical therapy in the deploy category. This is just a kind of a broad overview of our medical XR programs at Hoag, including both virtual reality and augmented reality. This chart on the right is the market share of global healthcare, virtual reality in healthcare in 2018. You can see the biggest pieces of the pie. One of the biggest pieces is in education and training. This is actually an area we have not delved into much yet. We are not a university hospital. We don't have residents and medical students, but we do have a lot of nurse training going on here. And so this is one of our big targets for the future. In fact, just a recent study I saw out of the NHS in Britain demonstrating significant decrease in anxiety level for frontline healthcare workers when they had a VR stress inoculation about how to deal with and properly manage COVID-19 patients. So you can see across the spectrum at Hoag, we are deploying VR for patient engagement, for medical legal protections, physical therapy, pain management, anxiety, and even nursing and staff wellness. There are some operational hurdles, which I'm going to talk about how we've cleared some of them. One of the biggest ones is infection prevention. This is particularly relevant in the COVID-19 era. We have pressed through with some technology, getting nurse buy-in to say, okay, the nurses have enough to do, how to offer this to their patients, physician buy-in, getting patient buy-in, how to protect health information, EHR compatibility, and of course, one of the big ones is reimbursement. The last one, we've kind of gone forward despite the lack of reimbursement. In other words, we feel that the value of deploying virtual reality for pain and for stress management, especially in the increased anxiety world in relation to COVID-19, is the value of deploying it for our patients exceeds the fact, or is more important than the fact that it is not reimbursed. In other words, our health system is willing to spend broadly because we believe that there's a positive impact, particularly in making a significant dent in opioid consumption, in global anxiety, and in other related conditions. So how have we solved the operational hurdle of infection prevention? We use clean box technology. We've actually kind of MacGyver engineered the clean box onto one of our WOW stations. So we put a battery pack in the floor of the station, so it charges the clean box as well as charges the headsets as they go. This allows the nurses to deliver the VR solutions from room to room, literally allowing us to engage every patient that has an interest in doing it, going from room to room, asking the patients, would you like to be involved? Would you like to experience virtual reality to help with your pain or anxiety? And sometimes they say, no, I'm not in pain, or I'm not anxious. But then when they try it, they realize that they actually probably were. This is how we got nurse buy-in. We started with our ground floor nursing team. So first, by having the nurses experience this, to see the relief they get during their day, to helping them to disengage from the stress of their day. In fact, we built a little virtual reality guided meditation room on one of our nursing floors and have been running a one-year study about the impact on their level of satisfaction and in helping them decrease healthcare-related burnout. This, again, is particularly relevant during the era of COVID-19. Of course, we're keeping them protected using UVC decontamination technology. So this is our nursing VR team, which is actually who are the ones deploying this. What we did is we took 8 nurses that would have been furloughed because some of the hospital units were closed due to COVID-19, and we reassigned them to be part of the virtual reality deployment team to get this project off the ground. So in addition to the ability to deploy these technologies and solutions to our patients, we're also keeping more of our employees at work by allowing them to repurpose to a new team to help with this initiative. What they suggested is creating a menu for the patients to choose from to decrease the confusion once they get into the headset. We have a printed laminated menu that we bring from room to room so the patients can choose beforehand, oh, I want to do escape. These are images from applied VR. So I want to choose the escape, or I want to choose the guided relaxation, so that they know what to expect. This further decreases the anxiety. And this is our results, our early data. So in a total of 6 weeks, we've treated 434 unique patients with ages 18 to 98. Average pain reduction on these patients is 3 points on the VAS scale. And just some of the quotes that we have: this helped me find a safe place within myself. This is the first time I've been able to sit up and eat since being admitted. No pain during VR, very relaxing, helped me fall asleep. There's again and again, the patients are giving us this feedback. So if we needed any further evidence to tell us that, you know what, we're going to go forward despite the fact that there isn't direct reimbursement for this, the fact that we're making this kind of an impact on our patients is enough evidence for us to keep this in the deploy category. This is just one example of a patient testimonial who, even after he went home, said, with the aid of VR, I've been able to better control my pain and work through it. I was even able to reduce my pain medication by half. Can you imagine if we have that kind of impact on every patient? Which is why we are not deploying this. We're not a university center. Our approach is to just, rather than set up clinical trials, to just deploy this in a wide scale effort, because we believe the evidence already exists based on work that will Walter Greenleaf has done, based on work that Brennan Spiegel has done, Beth Darnell, Adrian Lowe, a lot of these pioneers in the field of VR who have done a lot of this research. Now, I believe VR for pain and stress and anxiety is ready for prime time. And yes, we will work and are working with the FDA and CMS to get eventual reimbursement for us. But in the meantime, our patients need this now. We need ways to get these solutions to patients now. And that's why we've decided to just go ahead with it. These are some more examples of research projects we are running at Hoag at the moment. So in the next sphere of research, using virtual reality to decrease anxiety during chemotherapy infusion, using it in the PACU after gynecologic oncology surgery, after knee replacement. As I said, using it to decrease nurse-related burnout. And then multiple studies using augmented reality for guidance during neurosurgical, ENT, and other surgical procedures. If you think that we're not making news with this, this is on the national stage. I spoke at APAC on March 1st, the American Israeli Political Action Conference, and myself and Danielle were on stage to an audience of nearly 50,000. And right before us on stage was our Vice President, Mike Pence. Now, politics aside, to get us on stage with the VR headset in healthcare right after the Vice President of the United States, the impact must be pretty large. So people are paying attention, and once we get this kind of attention, soon we'll get the attention of the CMS and the FDA to get these things moving more quickly, because the need for these is now. We all realize that the collective anxiety level has probably 10x right now globally, and we need solutions in the hands of our patients. So we are charging forward with this at Hoag, and the impact that we've seen on our patients and on our community has been pretty profound. And I believe we're just getting started. To wrap up, this is our XR program team. So myself, I'd like to thank Walter Greenleaf, who's our special consultant from Stanford. We've brought him in to help us develop a lot of these strategies and bring in these technologies. My partner, Thomas Hutchinson, who is Executive Director of Operations for the XR program. And of course, our entire XR team, including our fellow, as well as the teams from the different institutes, neurobehavioral health, heart and vascular, the nursing lead teams, many of whom have taken these projects on. All of these are contributing to the rapid expansion of our XR program offerings at Hoag. I appreciate you guys having me here today, and thank you for the time.